Okay, thank you everyone for coming today. Thanks for joining us for this breakout session titled More Than Words, Supporting Communication and Swallowing in Huntington Disease. We're excited to have you here to dive into some valuable insights that we hope will spark great conversation and practical takeaways. Before we get started, just a few quick housekeeping tip items. This session will run for 45 minutes with time at the end for a Q&A. If you need to step out, feel free to do so quietly. The chill zone is open in the Carlton room for anyone who needs a break from this session content. With that, let's get started. I'm thrilled to be joined by our speaker today, Olivia Mann. Olivia is a registered speech-language pathologist with over a decade of experience working with adults across the continuum of care. Since 2013, her clinical focus has been in neurorehabilitation, supporting individuals affected by stroke, Parkinson's disease, ALS, and other neurodegenerative conditions. She currently serves as the professional practice leader for speech-language pathology at Waterloo Regional Health Network, where she oversees clinical practice, quality improvement, and strategic initiatives for both speech-language pathologists and communicative disorders assistants. Please join me in welcoming Olivia.
Thank you. Thanks so much, everybody. I'm so happy to be here, and whoever was here a couple years ago when is this feedbacky? Is this okay? A little bit? I'm gonna move it away. Who was here a couple years ago for the virtual session. I may have virtually seen you. Is that a little bit better? Okay, I mean, there's not many of you, and I do have a big voice for a small person. So thank you so much for coming. I'm so passionate about communication and swallowing and have been since even before becoming a speech pathologist. So this was sort of always my dream to always come speak with individuals and families with these conditions and try to be a voice of help or at least, starting of the next steps of what to do. So again, everything is my own opinion. I do work for a couple of employers. What I'm saying today doesn't reflect what they think, only what I think. I'm here for no financial gain at all. It doesn't replace any advice that you hear from your neurologist or your healthcare team. I am not a replacement for your speech and language pathologist, who you should all be connected with at some point, or your OT or anybody. So please listen to them over me. I am the generalist today. I am not your specific healthcare practitioner. If you would like to reproduce any part of this presentation, just let me know. My email will be at the end. Okay, so what is a speech-language pathologist? As kind of was mentioned, we work from anything from premature infants to end-of-life care. I particularly work with neuro patients, so anything from neurodegenerative conditions such as Huntington's, Parkinson's, ALS, to people who've had stroke or brain injury. So I look at how the brain communicates with speech and swallowing. So I always think from our diaphragm up. That's my expertise. I know nothing about the other limbs, so don't ask me. So what are we going to learn about today? At least a little bit. So hopefully you'll have some takeaways by the end. So how does communication work when you have Huntington's disease? What are some challenges that you find? What can we do to support communication as somebody who has Huntington's disease or as your care partner? How do we evaluate swallowing? So what might you expect from a speech and language pathologist or a swallowing evaluation, just so you know what you're getting into when you go for that? How do we manage swallowing in Huntington's, and what do we kind of expect to see as the disease progresses as well? So I am going to ask for participation. I will. Thank you. I know I see Toronto Blue Jays stuff. I was out trick-or-treating, not myself, my kids were, and we're all tired, but I do want we remember things by participating, so I might call on you, and I think that there's a fun crowd over here. So what is communication? Just be wrong loud. I don't care if you're wrong. I always teach my students to be wrong loud so that we can have our patients be wrong loud as well. We need to be comfortable. So I'm saying to you all, be wrong loud. What is communication? Give me words. Yep. Reciprocal dialogue between two or more people. Love it. What else? Yep.
The whole sequence of events.
No.
Miss Anderson, and then but then you have to hear it, and then you have to interpret it properly. It's a whole sequence of events. The breakdown can be anywhere.
Correct. Yes. Anything else? What's communication? Give me an easy word. Talking. Listening. What else? Texting. Body language. Good one. I am exuding confidence right now because I have trained myself to show confidence because I am the expert in speech and language, correct? Yes, that is what my hopefully body language is saying. Tone, thank you. So yes, thank you. So if I were to say, the Blue Jays are gonna win the World Series tonight. The Blue Jays are gonna win the World Series tonight.
They got a 50-50 chance.
Thank you. So I'm not changing what I'm saying. I'm using the melodic intonation of my voice to change what I'm saying. So important in communication. The Blue Jays are going to win the World Series tonight. We don't know. We don't know. 50-50. Well, I think they have more of a chance. Hope for the best. Hope for the best. So it all starts with the brain. So my brain is saying, I am speaking to a larger-ish audience. I am going to use my diaphragm a little bit more to have my voice project. My brain is also telling me to sequence the words in a certain way to make an intelligible sentence. What else is happening is as my diaphragm is expanding, as my ribs are expanding, it's telling me to take a breath and talk at the top of my breath. But my brain is also sequencing, okay, in your larynx, there's your vocal cords, and your vocal cords are going to be vibrating, so that's going to make sound. Then when that sound reaches your mouth, my lips and my teeth and my cheeks and everything is moving to create phonemes. Then I'm raising my tone, lowering my pitch, raising my voice, lowering my voice, and finally, that sound goes out into the air. That's not even half of it, but that's an overview. So the sound waves are going literally, physically to your ear, and you receive the message. Your ear is encoding that kind of analog data into digital data into our brain. And your brain is saying, okay, what'd she say? Or I agree, or whatever it is, or you're nodding, or you're shaking, or you're disgusted, or you're laughing, whatever it is, we have that communication. So yes, communication is physical, but it's also social communication, it's body language, it's all of these systems into one. Cool? Yes? There's a lot of points to be broken down. Yeah. Okay. So what do we find in Huntington's? I'm gonna grab my notes because I stayed out late last night and we watched the Blue Jays. So motor speech is this overall definition of what can happen with many neurological conditions. So with motor speech in Parkinson's, we find something called hyperkinetic dysarthria. Who's heard of that? It's a fancy word for slurred speech. So there's different types of dysarthrias, and sometimes what we find as speech and language pathologists, that we're usually one of the first people to see somebody with some sort of neurological condition, because the speech will tell us what's happening. So someone with maybe a more nasally voice, or someone who speaks like they're having a cold, actually tells us neurologically what's happening with someone. So sometimes we find that with kids as well, that their speech and their language patterns are sort of part of that puzzle in diagnosis. So we find with Parkinson's, with this type of dysarthria, hyperkinetic dysarthria, that we have kind of an imprecision sometimes of lip movement, tongue movement, cheek movement. And those are our articulators. So what would that do? If our lip movement and tongue movement and cheek movement is a little bit off, yeah, change the way that our words come out. They may come out slurred, they may come out a little bit imprecise, a little bit more unintelligible as well. We may have some oral and motor weakness and incoordination. So our brain may not be sequencing things properly. Things need to sequence in the right order to have that speech happen and that those sentences happen. We may see some breathiness with voice. We may see some hypernasality in the voice as well. And we may have some variable pitch and tempo that don't always correlate with those thoughts and emotions that are trying to be conveyed. Correct. And I will get to that. That's, you know what, I'm just going to say it now. Very interestingly, with if I say Parkinson's, I apologize. I do work a lot with Parkinson's as well. Huntington's. People with Huntington's preserve their comprehension, so their understanding, a lot longer than their verbal expression. So that's great, but that's where the frustration comes in, because you are aware of your speech is not how you thought it was going to be. You planned it in your brain, it's not coming out as you want, as you intended, or even the intention behind your speech is not coming out as you intended. So we also find some difficulties with tempo, or we find really quick speech. Sometimes people are speaking on the end of their breath. They're trying to get that word out or that sentence out before their breath runs out. Sometimes we find people speaking at the end of their breath, so it's really strained as well. And variations in loudness. So if there's background noise, we sometimes can't hear the person because they're not adjusting their speech and their loudness to the background noise as well. I see some nods that some of you have experienced this. So as I was saying with the voice as well, I've been describing some voice issues. Some respiratory control is sometimes an issue. So again, we should be taking a breath and talking at the top of our breath. Our language may have some issues, so difficulty with more complex sentences as the disease progresses as well. And also some social communication issues. So if we are not conveying what we're thinking and how we're feeling, our spouse or family member may say, wow, you seem really annoyed or angry with that sentence when maybe that wasn't your intention. And that can really affect your social communication. So we need to keep that in mind as well, that speech and language and swallowing really affect your social circle and your mental health as well. Okay. So with Huntington's, we again may find that irregular breakdown of speech. So sometimes we call that transient. So sometimes you may feel like you're really breathy. Sometimes you feel like you're more strained. It's transient at times. Patients may rely on nonverbal cues more so as some speech deteriorates, some body language cues, as speech becomes more intelligible. So patients and caregivers are under-recognized across the continuum of healthcare about the impact of speech and language. If you feel comfortable, has anyone been referred to or even known to speak to a speech and language pathologist at all? 1, 2, 3. Okay, good. That's good. That's positive. I've had crickets before. Yeah. And I'm like, okay, what can we do about this? So we need to build neural pathways now, prior to progression, to maintain function for as long as possible. Building neural pathways actually changes your brain and actually makes your brain heavier, so you're actually building on brain prior to progression. So that will help with maintaining function for as long as possible. Okay. So, Olivia, what can we do? So there are lots of different things and strategies that we can do. There's some, therapeutic strategies. There's some compensatory strategies. There's some AAC strategies as well. Will they get a copy of this presentation? Does anyone know? It'll all be filmed. So future you have it. so we may have some speech strategies. So let's try my favorite sentence right now. And I don't know why I wrote it down because I'm tired. Okay, let's just say, as you would normally say, the Blue Jays are winning the World Series tonight.
Sure.
Okay, let's try that again. I want you to think about over-articulating and over-exaggerating your mouth. I want it to look like this, over-exaggerating your mouth. So the sentence is, the Blue Jays are winning the World Series tonight. We're going to do it together, over-exaggerating. Ready? The Blue Jays are winning the World Series tonight. What happened? Did I tell you to slow down? What else happened?
Thinking about it.
Louder, thinking about it, clearer. What? How did that happen? I didn't tell you to do that, but you did. It was one cue that helps with lots of different modalities. You know what else I saw? Right before you took that sentence and believed in it with your heart as well. So one cue can help with all those modalities. So that's something that you can start implementing. Now, let me make a little caveat here. I don't think that everyone should be speaking like this all the time. No. But we also aren't in the gym working out with 50-pound weights when all we want to do is be able to play tennis, right? So when we're in our workout stage for speech, we overdo it so that we can generalize. So even if you feel a little silly in the moment with your speech pathologist or if you're practicing, the point is to create those neural pathways to do that outside of the clinic. Okay. So again, those clear speech cues, we're focusing on slowing our rate down, increasing loudness for clarity, emphasizing key words. So really trying to think about and slow down our speech. And it does feel awkward at the beginning, as well as things like breath support. So I want you to try something else. So again, the sentence is, the Blue Jays are winning the World Series tonight. If we say it more and more times, it's going to happen. So I want you to take a nice deep breath in, a nice deep breath out. I'm going to say the sentence, the Blue Jays are winning the World Series tonight. On that breath out. Did that feel good? No. So again, with Parkinson's, we find that people will start, so I'm doing this as my breath. So we find that people start their sentences at different points of the breath continuum. So we really try to teach to start at the top of the breath. You'll hear that as well. You may, when you go to your speech language pathologist, be shown some intelligibility drills where they will give you something specific and customized for your speech to work on. And if we look at, again, those motor learning principles, so what I was saying about building the brain and those neural pathways, we need to do things frequently, intensively, and specifically. So you may find that you have some drill work at home. Do it, because that's how you're building literally your brain. Think about it.
You're not supposed to do it just before you go see her.
Like brushing your teeth
Yeah.
before the dentist.
Yeah.
Oh, does nothing. They know. I feel like they know. They know. Oh, it's, you come in with bloody gums, and they're like, okay, all right. You haven't flossed in a year, my friend. Okay, I'm with you.
You said frequently, intensely,
And specifically.
and specifically.
Yeah.
Thank you.
So what else can we do to help? This is the most boring thing, and it's so important. So I gave this example, whoever saw me talk about this last time, don't give away the answer if you heard this before, please. So setting up a good communication environment. The lighting needs to be good. We need to be face-to-face with the person. The Blue Jays are not on for a second. Or any sports. We were reducing distractions. We're face-to-face with the person, and we're using any visual supports that have been identified for you to use. So if you're using a communication board or some sort of AAC device, which we'll go over, that needs to be available as well. So I once had a patient who, they came in, they're like, Olivia, we have tried. It was the spouse. It was the woman that said, I have tried to help, let's call him Dave, so many times. I have the lights off, it's on, the TV is off. There's no distractions. He cannot concentrate on what I am saying. It is driving me bananas. So I'm thinking, are the windows closed? Is the sensory overload diminished? So drafty windows, difficult. Is it too cold? Is it too hot? What is overstimulating for the person? Are they hungry? That is all part of creating a good communication environment. So we thought about it and thought about it. I said, what do you do at night that this always happens at night or in the evening? We put on the dishwasher. Now, dishwashers aren't very loud, but it was loud enough to just tip that cognitive overload to not be able to understand in that communication environment. They stopped doing the dishes at night, however that worked out, and they had a better communication environment. So just watch out for things like that. I've heard of the furnace turning on being too distracting as well. Just things you may not think about. Okay. Okay. Compensatory strategies. So compensatory means helpful strategies that aren't necessarily intelligibility drills, but things that may help you that are outside of your body. That's how I like to think about it. Who has a phone? You have so when I started 12 years ago, having an accessibility device was difficult to do. You had to get a prescription to get it. You have an accessibility device in your hand. An alarm is an accessibility device. What else? What else do you have in your phone that helps you every day? Calendar, camera, note taker, Siri. I use voice memo, all the things. You already have something that can help with cognitive abilities to help you now. So I encourage you to start using some of these things now. Why?
So you're more apt to use it when you have more problems speaking.
Yes.
Yeah, she's.
What? Say that loudly. You build the pathways. Yes. You pick up your phone in the morning, you set the reminder, or you do it right before bed. It's a motor memory thing that you can start doing now. So AAC stands for Augmentative and Alternative Communication, Augmentative and Alternative Communication, AAC. So, question, would we give someone who doesn't speak English, if they're presenting today, would we give them a mic? And that's amplifying their voice. Would that help you understand what they are saying? If I give you a communication board here, and you need to talk with the nurses in the hospital, is that helpful? No. AAC is important, but AAC is a tool that needs to be trained. I encourage everybody to start learning some AAC things, like things on your phone for help with remembering things, and talking with your speech pathologist about training not only the person with Huntington's disease, but the communication partners. I had a young man come in who was on a baseball team, and it wasn't his family that was supporting him. It was his baseball team, his baseball buddies. So they all came in. They all learned how to communicate with him, and he was able to participate in baseball. Actually, that's very funny that it's baseball, because I didn't even make that connection. So it doesn't necessarily have to be your spouse. Bring in your buddies to speech therapy. Bring in your loved ones, bring in your son, your kids, your whoever it is, bring them to speech therapy. Sending a person to speech therapy, just the patient, does nothing. Doesn't work. Never works with anybody. Kids, da, da, da. I shouldn't even say that. I am saying that. Don't hate on the SLP. They may be priced. I would love to come learn so that we can do these things at home. So, another caveat. You are not the speech therapist. You are not testing. Here, Dave, point to the dishwasher, point to yes, point to no. No. You are utilizing the strategies in your own communication environment. You're not doing testing. Does that make sense? Because I see a lot of people doing that. Okay. Point to the A. No. So you're sitting at breakfast. What do? Maybe you have a glass of milk. Maybe you have a glass of water. And sometimes we see that choreic movement. Do they point to milk or water? That is a compensatory strategy. They're pointing to what they would like, and you're giving them a way to tell you what they would like. What time am I going to? 11:45. Okay, good. No, I don't have to be anywhere, but I get off on tangents. Okay. Yes. So there are things called like communication technology clinics across the province or across wherever you're from, where speech language pathologists are trained to actually prescribe you a certain device that fits whatever you're going through. So you can always ask your physician or be connected with a speech language pathologist to talk about those devices and be introduced to one early. Some people may choose something like a speech generating device. You may want to save your voice. Some people want to maybe start recording phrases that they would say often. Now there are AI tools that actually learn your voice and speak in your intonation as it learns your voice. So there are some different speech generating devices that do that as well.
There are some nice programs.
Yes.
My wife has one on her tablet.
Totally. Yes. Like there's Perloquota Go. There's different avenues, and I'm not here to tell you which is the best. It's whatever works for you. It's a very hard conversation to have in terms of AAC devices, because it's knowing that when speech becomes more intelligible, you may need to rely on something else. Try and be proactive, but I very much appreciate that it's a very difficult conversation. Okay, and I've already been alluding to this all throughout. My whole thing is partner training is so important. We, at baseline, assume competence. What does that mean? The person you're speaking with, the person with Huntington's, understands.
You take for granted they are communicating exactly what they intended.
Yep.
And that they understand what you're saying.
Mm-hmm. Again, comprehension is not as impaired, even in end stage, as expression. Yep. So we always assume the person understands. So we try and front load multimodal communication. So that means speech, that means body language, that means things in the environment. Would you like juice? Would you like water? And we utilize those things to help get more input into the brain as to what you're saying and allow the person choices so they can get out what they want to say. So we'll call that message out and message in. And then we want to verify, did you want the water? Is this what you wanted? You did want the water? Okay. Sometimes we'll use a yes-no board as well. Again, we're not testing the patient. We're using multimodal communication strategies in context. Okay?
Olivia, just the way you just asked me about the water, your facial expressions seem to present a negative. Did you want the water?
Did you want the water? Okay. Did you want the water?
I just felt negative, so
You're totally right.
I'm going to feel, oh, hang on a sec. Maybe I don't want that. Maybe I shouldn't want the water.
You know what?
No.
John, you hit the nail right on the head, what I tell students too. Thank you. It was a test.
Nice spin.
Yes, that was a test. You're totally right. Because I didn't ask a yes-no question, did I? How would I ask that question? So Patrick wants the water. And how do I ask?
Is the water what you want?
Is this right? John, you're hired. Yeah, but it's really hard to do those yes/no questions and not show intent. I just did it, and I have 10 years experience, over 10 years experience with neurodegenerative, and yeah, totally right. I'm gonna show this clip to my students. See, students, I can make a mistake too. Okay. So we've looked at communication challenges and how to maybe baseline support communication with Huntington's. And let's have a quick look at swallowing as well. So here's what we all look like. If we have a sagittal plane, a cut into our head, we have our tongue here. It's giant, it goes all the way to our chin. We have this huge nasal cavity up here. We've got our trachea, so this goes to our, thank you. And this little bitty thing back here, this is our esophagus. It goes to our, what do you notice?
What a size difference.
Yes. So our trachea wants to stay open. It has these cartilage rings that keeps it open, which is great. But in this area, it's a shared pathway. Uh-oh, that's not great. It's good for our speech and communication, but we have a shared pathway right here of stomach or lungs pathway, right? So the point of swallowing is to protect this airway. It's to get food down to the stomach to give us nutrients, but it's to protect our airway. So just quickly, I won't go through every single beautiful stage of swallowing, but essentially what happens is this. Some people find comfort, here, I'll move this. Some people find comfort in knowing how the swallowing works. Some people find it icky. All right, so the food is chewed up, chewing the food. Our brain tells us, okay, the food's ready to go down. And as the food comes to the back of our tongue, our palate moves, this little epiglottis goes down, and it blocks off our airway as the food goes down. This isn't a typical swallow. Has anyone ever coughed on water? What happens when you cough on water? You're coughing, sometimes you're having tears come down, your eyes are red.
Water can even come up through your nose.
Yes, sometimes this area is not closed off during the swallow, and food and liquid can come out of our nose. That does not feel good when that happens. But our natural reaction is to cough, 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 cough. Any little food or liquid that heads down the wrong way is usually coughed up. So the food goes down to the back of our tongue and heads down into our esophagus. What happens at that point too is as we're swallowing, our vocal cords close in order to hold our breath. So as we're swallowing, our breath is held and the food goes down into our stomach. So I just want you to just swallow your saliva for a second. What do you do right after swallowing? Out, right? You're breathing out. Why do you think that is?
Before you swallow, you have breath in.
You might.
Yeah.
Now everyone's to clear it. Yeah. If there's anything that's headed down the wrong way, our natural body reaction is to expel the air out in order to get any little bits that have snuck into our trachea. We don't want that. So that's in a normal swallow, or in a typical swallow. So our swallowing actually starts, I see some of you with coffees, it starts with that motor movement to our mouth. Our brain says, oh, we're gonna swallow that. I see the size of the bolus, that's big, that's small. I'm gonna take a large sip, I'm gonna take a small sip, and our body adjusts for that. Our tongue adjusts for that, our pharynx, this little area in the middle, before heading down to our trachea or esophagus, everything adjusts for that bolus. And I say bolus because that just means the gooey thing that forms once you chew all your food up and it is mixed up with saliva and it goes down your throat. I wanted to take a quick mention that some medications can also affect swallowing. So xerostomia, which means dry mouth, can be affected by some medications. Having a really dry mouth, it's really difficult to swallow. So sometimes we tell patients just take a few sips of water before eating, and sometimes that helps with the lubrication of swallowing. Like if you take pills or something like that, having some water before and after medication is sometimes helpful as a quick tip. Okay, so what might you experience if you are going to see a speech pathologist and you're doing a swallowing assessment? It might sound like a big scary thing or a big deal, but you have 3 choices that the speech pathologist will say, you need this, this, or this. So there's a clinical swallowing exam, there's a video fluoroscopic swallowing exam, and there's a flexible endoscopic examination of swallowing. So a clinical swallowing exam, the speech pathologist will evaluate your cranial nerves. And all that means is how your nerves are telling your body how to swallow and in what sequence. Are all the muscles working properly? Are they working in the right sequence? And they may feel your throat. They may make you do some faces to look at how all those nerves are working. A video fluoroscopic swallowing study, also known as a cookie swallow or modified barium swallow, takes many X-ray pictures to create a video. So this is what that looks like. So all you'd be doing is you'd be eating and drinking with the speech pathologist in the medical imaging suite, and they will be watching you swallow. The food has some barium in there too, so you can see it. So here's some water, and the person swallows. That's okay. Good reminder. Excellent use. So what do you notice about the swallow right away? Fast. So that once that bolus gets to the back of your mouth, it's less than a second in a typical swallow for all of those things to happen to protect our airway. So there's that, and there's also this flexible endoscopic examination of swallowing. So essentially what that is this small flexible endoscope. You might have some lidocaine sprayed up your nose. The little camera goes to the back of your nose and looks down at your anatomy. So here's what that looks like. So you can see going through the nose, it does not hurt. And this is the back of the tongue, and there we go. So this little flappy thing here is called the epiglottis, and that's the thing that flaps over to protect your airway. Look away if this makes you squeamish. So you can see way down here, you'll see the person talking and their vocal cords are moving. See down here? Those are the vocal cords, and that whiteout is when a person swallows. So we can see from here anatomically, and we look at residue and things like that. We look at how things are moving in your swallowing in order to make recommendations to make your swallowing safer, or how to improve your swallowing with perhaps some strategies. Okay, so a swallowing issue is called dysphagia, and essentially what dysphagia is any part of that swallow, from bringing the food to your mouth, to it going down your esophagus, to your stomach, any part of that swallow is affected. It can also be affected by respiration, and as I've been talking about, respiration is so important in communication and swallowing. That timing of respiration is important. We find sometimes if the timing's off, someone may have a drink or some water or food and take a breath in, and that may cause them to aspirate. Aspirate means little particulates get into the trachea and you cough and cough and cough. Aspiration is important to note because if you're aspirating, it may cause something like an infection, like a pneumonia, and that's kind of what we're trying to avoid in swallowing care. Okay. So how does Huntington's affect swallowing? There are several different aspects. So we have those choreic movements. So if you have that food in your mouth and you're having some hyperflexic movement or movement around, it may move that bolus or have that bolus go down into your throat prior to having that trigger of the swallow, which is the protection of the airway. And this could affect every stage of your swallowing. We may see some sort of apraxia. So apraxia is kind of the blueprint of what you're doing. So your brain telling you the sequence and how you're doing things. There may be some apraxic issues of motor planning the swallow, or even, again, all of this is very similar to communication. The planning of communication, the planning of swallowing may be a little bit off as well. Swallowing is that sequence of 50 muscles. So imagine the innervation and the sequencing having to happen with the swallow. There may be some dystonia as well, so involuntary muscle contractions can affect any part of the swallow, tongue rigidity as well, difficulty making that bolus and actually chewing up the food. So if the food is not kind of in that squishy ball, it's a little bit harder to swallow and avoid the airway as well. We may have some rigidity in the jaw, which could affect mastication, slow, uncoordinated movements as well, and cognitive changes. So this is a big one that I see with Huntington's patients is they'll take a bite and not realize that it's a really, really big bite, and then their body isn't necessarily ready for that big bite or lots of successive bites and sips. So we find that a lot, and there's some things that we can do about that as well. We see teeth grinding, and again, that excessively fast eating as well. I'm seeing some nods in the audience. I went over most of these. So again, all these cognitive impairments and muscle impairments can affect any stage of the swallowing, bringing it to the mouth, the chewing, the actual swallow, and heading down to your esophagus, to your stomach. Sometimes we also find that there's reduced cough strength. So if something goes down the wrong way, they may not always bring it back up. How are we doing for timing? 4 minutes. Okay. So essentially, I'll give you some quick tips. Look, I'm at the end. I'm doing very well. So a couple of things that can be done now. That researchers agree that dysphagia or swallowing difficulties in Huntington's should prioritize symptom relief and quality of life. So how do we reduce the symptoms of dysphagia in Huntington's? So we want to keep our feet grounded. Oops. We want to support head and neck. We may bring an OT in to support head and neck to make sure that we're more still during eating. We don't want to be eating on a lazy way. We don't want to really be eating on a couch where your posture is a little bit off. 90 degrees helps with safety of swallowing. It encourages gravity to go the right way, food and liquid to go the right way. We may use adaptive silverware. I sometimes tell patients that the best thing to eat everything with is a teaspoon. So a smaller spoon will not allow more things to go on your fork. Sometimes I also recommend a spork, where not a lot of food can go at the same time on one bite as well. Sometimes we use weighted dishware as well to give more proprioception and feedback to our brain that we have something in our mouth or in our hand that is coming to our mouth as well. You may find that the speech pathologist may recommend altering the texture of your food. So if it's puree, maybe you have some difficulty with mastication, maybe puree is a little bit easier to eat, or food that is more like of a casserole style. You have to talk with your SLP about those recommendations. Sometimes we recommend some thickener in our drinks to help with slowing down that fast water. Maybe it slows down the speed so we can have a chance to actually swallow and protect our airway as we swallow. We talked about the dentist. Okay, how fast does plaque reform? We brush our teeth, how fast does plaque reform? 24, I wish. Well, not I wish, but 24 hours. 24 hours a day, yeah. Brushing your teeth, the actual brush movement is what takes off the bacteria. We are aspirating all day and all night. So there's little bits of saliva that go into our lungs all day and all night. If you have a clean mouth, no problem. If you have tons and tons of bacteria and pathogens, you are aspirating those pathogens with the water or your saliva into your lungs. That is a recipe for infection, pneumonia. And you said it? Pneumonia, yep, could be, yep. So oral hygiene is so key. Using a non-alcohol mouthwash, if you use mouthwash, is key to not dry out your mucosa as well. We do not want dry mucosa. That is, pardon? Yeah. Alcohol will dry out. I'm not your dentist. Please take your dentist's advice. We recommend no alcohol only because of the drying factor of alcohol, and it may dry out the mucosa in your mouth, and then you have actually more surface area for pathogens to grow. There's some research about that. Great. Toothbrushes are better than mouth swabs. If you've ever been to a hospital and they mouth swab your mouth, that does nothing. It's the mechanical brushing of your teeth that takes the bacteria away. Okay, so
On toothbrushes, get the Oral-B motorized toothbrush.
we are not sponsored by Oral-B. I'm just joking. I agree.
But I mean, just what find is your HD.
Yep.
Physical abilities suffer some, then you're brushing your teeth suffer. You're not brushing your.
Yeah.
Great job of it.
I love that idea. Just holding it there actually does a lot more with the mechanical toothbrush for sure. Yeah. I would rather you brush with just water than like just mouthwash and that's it. So brush. Okay, single sips, single bites. Don't take another bite until you've swallowed that first bite. Sometimes what I do is have different spoons already having food on it, and they will eat each spoon in a sequence. Smaller, more frequent meals is helpful. Pausing, having a bite, pausing, encouraging not speaking while eating. Sometimes we find that as well is some cognitive decline. People will speak or laugh or talk, and that just opens up the airway for possible aspiration. Early intervention is key, and we want to set up that really nice communication and swallowing environment. Same principles.